Dr. Pearlz clinical rounds here with the clinical case on acute complicated UTI in adults. Let's get right into it. 40-year-old female with past medical history of hypertension on lisinopril presents with 7 days of worsening moderate dysuria, urinary urgency, and lower abdominal pain. Patient reports new fever, chills, nausea, and right-sided flank pain for the past 2 days. Patient has tried over-the-counter phenazopyridine without relief and has been taking acetaminophen for the fevers. LMP was 2 weeks ago. Patient denies history of STDs or recent exposures. Review systems is negative for vomiting, diarrhea, and vaginal discharge. Patient is allergic to penicillin and reports only a history of urticaria. Vitals and exam are significant for a fever of 100.7, right CVA tenderness, and suprapubic abdominal tenderness. It is important to assess for abdominal tenderness and for costovertebral angle tenderness when the presentation is suspicious for a UTI. The costovertebral angle is an angle formed by the spine and the 12th rib overlying the kidney on each side. Tenderness may be elicited in the presence of renal pathology such as infection or stone. Additionally, a pelvic exam for uterine or cervical motion tenderness may be indicated in sexually active women when symptoms are not consistent with the UTI and there is concern for pelvic inflammatory disease. What diagnostic testing is indicated? A urinalysis to assess for the presence of pyuria, a urine HCG test in women of childbearing age, and a urine culture should always be performed. Positive leukocyte esterase and nitrites have higher sensitivities together for a UTI than each test alone, but nitrites are more specific for a certain gram-negative bacteria. Test results should always be used in conjunction with symptoms when diagnosing UTI. In our patient, the test results were significant for a negative urine HCG test and a dipstick urinalysis positive with 500 leukocytes, positive nitrites, 1 urobilinogen, 5 ketones, 1 bilirubin, and 200 blood. Phenazopyridine may cause false positive UA results for bilirubin, nitrites, and urobilinogen. It may also cause the urine to appear orange. Let's look at the local community antibiogram. E.coli and other Enterobacteriaceae have a greater than 10% resistance to fluoroquinolones. We will review the significance of this later on. Based on the patient's presentation, physical exam, and urinalysis results, the patient has an acute complicated urinary tract infection. So what distinguishes an uncomplicated UTI from a complicated UTI? Uncomplicated UTIs may present with symptoms of dysuria, suprapubic pain, urinary urgency and frequency, and hematuria. Complicated UTIs present with systemic symptoms such as fever, chills, nausea, vomiting, malaise and fatigue beyond baseline, CVA tenderness, flank pain, and or pelvic or perineal pain in males. Pyelonephritis is a complicated UTI with inflammation in the kidney due to a bacterial infection. While the classic triad of symptoms are fever, CVA pain, and nausea vomiting, these symptoms do not have to be present together at the same time. So how does one develop a complicated UTI? Let's take a look at the urinary system. The lower urinary tract consists of the bladder and the urethra, while the upper urinary tract consists of the ureters and the kidneys. Most commonly, bacteria may ascend from the urethra to the bladder, then to the ureters, and then to the kidneys, but there are other potential mechanisms. In men, for example, infection may originate from the prostate due to prostatitis. Hematogenous spread is another possibility, but this is uncommon. What risk factors increase the risk of developing complicated UTIs? Immunocompromised, such as HIV or malignancy, poorly controlled diabetics, those who have underlying urologic abnormalities such as kidney stones or stents, and urinary obstruction are at an increased risk. Other risk factors include older age, pregnancy, and male sex. What are the potential complications of a complicated UTI? If left untreated, complications such as sepsis, bacteremia, shock, and acute renal failure may develop. It is important to always review the vital signs, as abnormal vitals must be addressed. Vital signs are used in the SIRS criteria when screening for sepsis. What pathogens cause complicated UTIs? E. coli is the most common pathogen, but organisms such as other Enterobacteriaceae, Staphylococcus, Pseudomonas, Enterococcus, and others can cause UTIs. When a complicated UTI is suspected, always send a urine culture and review any previous existing culture results to help guide empiric treatment. Don't forget to reference the local antibiogram. What is the management for complicated UTIs? For mild to moderate cases, most can be treated successfully as an outpatient. As a first line, when the prevalence of resistant community pathogens to fluoroquinolones doesn't exceed 10%, ciprofloxacin or levofloxacin is recommended. Duration may vary. When resistance exceeds 10%, a one-time dose of IV or IM ceftriaxone is recommended. If ceftriaxone is contraindicated, a one-time dose of an aminoglycoside such as gentamicin can be used. A parenteral antibiotic may not be readily available, so it is important to monitor closely for clinical improvement. Avoid fluoroquinolones if the patient is pregnant, has a history of QT prolongation, tendinopathies, aortic aneurysm, or is allergic to fluoroquinolones. An alternative is trimethoprim sulfa. If susceptibility to TMP-SMX is unknown, an initial parenteral agent is recommended. In our patient, the use of TMP-SMX may cause dangerous hyperkalemia when taken together with lisinopril. Additionally, the local antibiogram shows E. coli resistance of 35% to TMP-SMX compared to 28 and 24% for Cipro and Levo, respectively. Although nitrofurantoin only has a 9% resistance to E. coli, it cannot be used to treat pyelonephritis as it does not reach therapeutic levels in the upper urinary tract. Beta-lactams such as amoxicillin clavulanate, cefadroxil, cepodoxime, and ceftonir can be used if fluoroquinolones or TMP-SMX cannot be used. An initial parenteral agent is recommended. Keep in mind beta-lactams have lower efficacy. In our patient, E. coli community resistance is greater than 10% to fluoroquinolones. As there are no previous available urine cultures, an appropriate first line of treatment is a fluoroquinolone with the parenteral administration of ceftriaxone. Patient has a penicillin allergy that results in urticaria. Ceftriaxone's cross-reactivity with IgE-mediated penicillin allergic patients is less than 1%. TMP-SMX is avoided for two reasons. E. coli community resistance rates are 35%, and the patient is on an ACE inhibitor for hypertension. Follow-up. Follow-up is recommended within 48 to 72 hours of empiric antibiotic treatment for clinical reevaluation. Most culture results should return in 2 to 3 days, so tailor the antibiotic regimen if necessary. More importantly, if the symptoms are worsening and sepsis is suspected, further evaluation in the emergency department is required. Other indications for hospitalization include pregnancy, concern for urinary obstruction, or the inability to tolerate oral intake due to persistent vomiting. This is not an all-inclusive list. That is all today with Dr. Pearlz Clinical Rounds. Thank you for watching, and don't forget to hit the like and subscribe button. Let's move on to the next case.